Dr. Scott is the Executive Director of the New Mexico Primary Care Training Consortium and College Professor in the College of Arts and Sciences at New Mexico State University. She received her BA in Women's Studies from Duke University and her MA and PhD in Anthropology from the University of Kentucky. Her work focuses on developing curricula and other tools to improve training in health equity in primary care residencies. Her research has been funded by the National Science Foundation, Fulbright, National Cancer Institute, the New Mexico State University College of Art and Sciences, and Southwest and Border Cultures Institute, and the Loomis Foundation. Her work has been published in Family Medicine, Collaborative Anthropologies, Journal of Interprofessional Care, and Qualitative Health Research, among other journals. Nicole Mandall graduated from New Mexico State University with her Master's of Public Health. She has worked on many projects to promote health equity, both at home and globally. Examples include reducing stigma about people living with HIV and AIDS in Ukraine, promoting gender equality and sexual reproductive rights in Ethiopia, and unveiling rates of domestic violence among pregnant women in the border region. Currently, she is working as the Director of Operational Development for NMPCTC, where she leads the team dedicated to improving health in New Mexico. So with that, go ahead, Dr. Scott and Nicole, take it away.
Thank you for the wonderful introductions, Amanda, and thanks for having us. I'm not muted. Okay, yeah, good. Dr. Scott, did you want to say anything before we get started?
No, just thank you all for being here, and thanks, Amanda, for those introductions. And we're excited to talk today a little bit more about integrating health equity training into residencies, but I will turn it back over to you, Nicole.
Awesome. Great. Okay, so I wanted to start this session with a little bit of interactive with everybody. So I want you all to get out your phones and scan this QR code. And it's going to take you to a little poll that says, what in one word, how do you describe health equity? So I'll let everybody do that. And while we are going, I'm going to switch over so we can see everybody's answers. Does everybody have the QR code scanned? Okay. And you can answer multiple times if there are different words that come to mind for you. So let's bring up. Is everybody seeing a big white screen and access right now? Yeah, okay.
Nicole, should things be coming up if we've entered them?
Yeah, are you guys not seeing it?
It's still blank for me.
Okay, let's see. How about now? Can you see those?
Yes.
Okay, I'll leave it on this view then for everybody. So you can see here in this word cloud, the most entered words appear a little bit bigger. So it looks like access is one that is on the tops of everybody's mind. We have community, community flourishing, care, everyone, structural, advocacy, quality. All great words to describe equity and kind of get us kicked off into quality coming up there. Yes. Up into our discussion today. All right, so you can continue doing that if you would like. I'll save the cloud at the end, so everybody, I'll send it out to everybody. Let's go on to our presentation. All right. Okay. So Next, I have a little video, and I know a lot of you know what health equity is, but if you're dealing with a resident or somebody in the community, you want to describe what health equity is, this is a great tool if you want to show it to them to kind of describe what health equity looks like and what it is. So let me start this. Sorry, gotta get buttons in the right area.
We start to ask questions. We may start to wonder.
Oops, sorry.
Okay.
We each have our own history and unique story. The people around us have their own stories and histories. Together, our unique stories and histories shape our world. What you might not realize is that our world also shapes us and shapes our health. Together, our environment and our neighbors make up our community and the fabric of our lives. What would we see if we looked closer at our community and the communities around us? What if we looked just below the foundation, at the roots? Throughout history, some communities have received less than others. Still today, things like housing, income, education, and our sense of belonging in society are not the same in every community or for every person. Yet they directly benefit or hurt our health. But how do these things affect health? Let's take a closer look. Some people live in communities where they have fewer opportunities for better education, fresh food, safe housing, or jobs that pay enough to meet their basic needs. Each person's health depends on their living and working conditions, as well as the resources available to them. Where we live and work and the types of resources we have access to are interconnected, often overlap, and vary within and across communities based on the history, culture, norms, attitudes, behaviors, and lived experiences of people. When we begin to understand that our communities impact our health and we pay attention to the world around us, we start to ask questions. We may start to wonder, what if? What if we could start at the root by investing in our neighborhoods, communities, and larger society? Could we create a world where everyone has the same opportunity to be healthy? Even if it doesn't always seem like it, we have the power to shape the world we live in. We can make things different and better and fair for everyone. We can create health equity. Health equity is the opportunity for all people to be able to attain their highest level of health, regardless of where they live or their personal stories. Addressing health issues at the individual level is not enough. It is far more powerful when we help everyone in a community at once by making changes that affect their physical, built, social, and policy environments. To achieve health equity, we rely on connecting science, policy, and practice to put real change into place. That's where public health can play a major role in helping to achieve health equity. When public health champions work collaboratively with those of housing, transportation, and education, we can move towards creating fair and equitable opportunities for everyone to be healthy. Health equity begins to happen when people in communities engage with one another and explore policies, programs, initiatives, and services that are centered on their shared problems and successes. With the right collaborations and initiatives, we can create a society where all people are healthier, safer, and able to play, grow, learn, and live in places that promote good health. It takes all of us to show up, to have conversations, to decide what resources we need and what actions we can and should take to achieve health equity. Learn more, take action, make a difference. Visit cdc.gov.
All right. So if you guys are like me, I'm a very visual learner, and I feel like this video just puts it in a really great, it frames what health equity is in a really great way. So great resource, and you'll have that with you after this session. So we'll go on to a little, different. Here are some agencies in the US and in New Mexico and how they define health equity, because each person, each organization has a little bit a different spin on it. So you can see HRSA here says that health equity is the absence of disparities or avoidable differences among socioeconomic and demographic groups or geographical areas in health status and health outcomes, such as disease, disability, or mortality. And then APHA here says that everyone has the opportunity to attain their highest level of health. It's nice, general, all-encompassing. I kind of like this one. And then the New Mexico Alliances for Health Council says that health equity means that everyone has a fair and just opportunity to be as healthy as possible. Achieving this requires removing obstacles to health, such as poverty and discrimination, and their consequences, which include powerlessness and lack of access. Access was one of our big words that we did in our word cloud, so you guys got that. Quality, another big word, quality education, housing and healthcare, and safe environments. So good job, you guys you're on the right track. All right. And then here is just a little graphic that I like that shows the difference, because there is a difference between equality and equity. So equality is really giving everybody the same regardless of their need or right. So you can see that we are all differently abled. And so equality doesn't necessarily get us to the goal of equity. So giving everyone what they need and understanding the barriers, circumstances, and conditions in their lives. So you can see the differences in those two pictures there. All right. And I'm going to hand it over to Dr. Scott so she can delve a little bit more into health equity in the realm of ACGME and our residency programs.
Yeah, thanks, Nicole. I'll say really quickly, I think, for me, one of the really key things about thinking about two things I think that are really important in thinking about equity, and I think are, we can think about the ways that we teach our residents this. One is exactly what Nicole just mentioned, the difference between equity and equality. And so making sure that people have what they need, and not all people need the same things. But if we provide access to more people, that usually benefits everyone. And so I think that image of the sidewalk with the ramp instead of the cliff off the sidewalk, that helps not just the person who's in the wheelchair or the person who's blind. It also helps everyone get from the sidewalk to the street a little bit easier. And so I think that's important to recognize, is that when we think from an equity perspective, we actually really are creating more access for all of our communities, not just the people who necessarily have particular issues. And then I think the other thing is that I really also like the APHA definition of health equity, that everyone has the ability to attain their highest level of health. Not everyone is going to be able to attain the same level of health, right? Some of us have chronic conditions that may limit our ability to be as healthy as someone who doesn't have that chronic condition, but we can maybe be healthier than we currently are. So just as an example, say someone who has asthma may not be able to engage in as vigorous exercise as someone who doesn't have asthma, because their lungs just have a different capacity. But maybe they can engage in more than they're currently engaging in if they have access to appropriate healthcare that helps them keep that asthma controlled. So I think those are really important concepts to understand when we're thinking about health equity, and especially how it applies to healthcare. So, and now, sorry, Nicole, I jumped back to some of your other slides, but thanks. I love those slides. So wanted to make a couple comments. So the ACGME and the specific RRCs, or the specific groups that develop program requirements for the different specialties have recognized, and actually for a long time have recognized, that health equity is an important concept to teach in residencies, but it's become more and more explicit as we've seen revisions in program requirements recently. So in general, typically where we see health equity the most in the common program requirements is in the area of systems-based practice, which is one of the 6 core competencies across all residency programs, so regardless of the specialty. And so what this competency now says is that residents must demonstrate an awareness of and responsiveness to the larger context and system of healthcare, including the structural and social determinants of health, as well as the ability to call effectively on other resources to provide optimal health care. So I want to focus us in on the structural and social determinants of health. That's in the common program requirement. So that's across all specialties. And we'll see that gets more specific in some specialties than others. But I'm curious, just for the people who are here, are you all familiar with the concepts structural determinants of health and social determinants of health? Are those familiar concepts to everyone? Or should we explain? I'm not hearing anything from anyone. So I'm going to maybe assume that maybe not everyone knows. So I'm just going to give a really brief explanation. So when we talk about social determinants of health, some of that was in the video that you saw. So those are things like access to transportation, access to healthy foods, sidewalks in a community that give you the ability to exercise safely. Those are what we would think about as social determinants of health. So they're things in our social environments that have an impact on how healthy we're able to be. When we talk about structural determinants of health, we're talking at a little bit higher or a little bit broader level than that. So we're often talking about policies that might be in place that could have an impact on health. So I'll just give one example. In Las Cruces, there's relatively recently was a minimum wage policy that was passed that increased the minimum wage for certain businesses over a certain number of employees within the city. And so businesses are required to pay that minimum wage. And part of the idea there was really thinking economically that the previous minimum wage, it just wasn't enough to live on. I don't know that the current minimum wage necessarily is, but at least it's closer, right? But if we think about that from a health perspective, what that means is that people have more economic resources that they could use for things like healthy food or paying for transportation to get to the doctor's office, or paying the copay that they need to pay to be able to see their physician. And that policy is a structural determinant of health. And in this case, it helps, but we often have policies that might not help. So just to explain, that's what that is. And we are supposed to teach that to residents. So residents should understand, be aware of that context and that their patients live in that context and be responsive to that. And that's a hard thing to teach. So that's what we want to talk about today. So I'm going to talk, we can go to the next slide. I'm just going to give examples from 4 different specialties, just so you can see the different ways that it comes up across different specialties. So within family medicine, when we look particularly at patient care, this is actually not in systems-based practice, it's in patient care, but one of the things that it talks about is that residents must demonstrate competence, and I'm going to skip to the last line, in understanding allostatic load and the structural determinants of health. So this is part of patient care in family medicine, is understanding allostatic load or stress, and the impact of stress and structural determinants of health on patients' health, and how that would impact their care. So that's something important that we need to teach in family medicine. We can go to the next one. I'm going to go through these a little bit quickly. In pediatrics, one of the things that we see, this is also in under patient care, residents must demonstrate the ability to provide comprehensive medical care, but that includes incorporating the impacts of social determinants of health and advocating for social justice. So within pediatrics, advocating for social justice is seen as part of patient care. So teaching residents how to advocate is part of what we should be teaching in pediatrics. And we can go to the next one. In internal medicine, under interpersonal and communication skills, It talks about being able to communicate with patients and patients' families across a broad range of socioeconomic circumstances, cultural backgrounds, and language capabilities. This might look familiar. There's very similar requirements in other specialties, including family medicine. And what I think what's being pointed out here is a recognition that patients are coming from these different social and structural contexts. And in order to be able to communicate effectively, we have to understand what those contexts are and how they might be impacting patients and the relationship between physicians and patients. And we can go to the next one. And in psychiatry, under medical knowledge, and again, this is similar. There's a similar one in family medicine as well. But residents must demonstrate competence in their knowledge of, and this whole list, right? Biological, genetic, psychological, sociocultural, economic, ethnic, gender, religious, spiritual, sexual orientation, and family factors that significantly influence development. So that really means needing to understand this entire context that patients are living in, which is relevant for health equity. Okay, we can go to the next one. Oh, this is back to Nicole. So let me summarize really quickly. I just want to point that out because this is really health equity issues are woven across program requirements throughout primary care. And so this is something that is really important to teach. It also really strongly impacts our patients. So I'm going to turn it over to Nicole to talk about that.
Dr. Scott, that was a wonderful introduction into our ACGME requirements. And going above and maybe a little bit further than the requirements, like why should we care in New Mexico? And the answer is it's really impacted here in New Mexico. We have a lot of health disparities, social determinants of health that disproportionately affect a lot of our population. So I'm going to just go through and give a few examples. There are many more, and I'm happy to talk more offline about those with you guys, or we'd be here all day. But some of the key ones here, 25% of New Mexicans live at or below the federal poverty level. Poverty being a big structural determinant in our health. And then 1 in 3 of New Mexicans live in rural areas, and this goes to access, infrastructure, education, a lot of different things that happen when you live outside of urban centers. New Mexico has a healthcare provider shortage, which negatively impacts preventative care and access to treatment. And we are all doing the work on addressing that healthcare provider shortage, but it's still something that we need to look at. Obesity and diabetes among New Mexico youth are disproportionately higher in Native and Hispanic populations. Diseases of despair are highest among Native Americans, with New Mexico ranking highest for alcohol-related deaths in the nation. 35% of New Mexicans speak a language other than English, which isn't necessarily bad, but again, that goes to access and finding your way to adopt the same language as you, and can have some health New Mexico's minority majority population has suffered root shock, historical trauma, and the effects of colonizations, leading to systemic racism and social injustices, which I feel like we could take that statement right there and have this whole conversation again. So that's a really, really big one. And then one that I just looked up the other day for this presentation, and I didn't realize that it was so bad, but New Mexico ranks 50th, the worst out of all the states in percentage of adverse childhood experiences. So just a quick little recap of what that is. This is a survey between 0 and 17 years of age of children that have these experiences of witnessing violence, of seeing trauma at home, of being, hungry at home, things like that. So something that also affects us here in New Mexico. Any questions about any of those or anything we've talked about so far? Okay, we'll keep on going. So, let's have a little bit of audience participation, if you guys will. We're gonna just pull it out of you. So what kind of the health disparities, it doesn't have to be necessarily in your practice population, but like in your community, in your church, in your grocery store, you know, in your doctor's office that you visit, what kind of health disparities do you see around you here in New Mexico? And NMPCTC people you can jump into.
I would just like to agree with what you were talking about us being last, New Mexico being last in health. I can't remember exactly what the slide said, but we're last in not just that, or like early childhood experiences, is that it? But like education and a lot of things, and us being the number one for alcohol abuse. Is that what you said? In the nation? Yeah, that's really some things that I see. And of course, almost everyone lives in a rural area unless you live like right in Albuquerque or Las Cruces.
Absolutely. Thank you, Joy. And it's nice to finally meet you in face-to-face Zoom.
Yes, I was gonna say that too. It's nice to put a face to the name. Thank you. And part of the reason I have my video off sometimes is because it lags a little bit with the wind blowing like it is here. So if I turn my video off, it helps with the audio.
No problem. And that, looking at the chat, Nora, Dr. LaMartine says lack of internet access. So that's definitely the one that we face. Language, transportation, rurality, absolutely. Then Dr. Scott, what are we saying here about ACEs, adverse childhood experiences for children from lower income families? Yes, in your partner's elementary school. Lack of behavioral health resources for youth, absolutely. Anybody else want to add in?
I think something that hasn't been mentioned just in terms of access, but food deserts, right? So typically in rural areas, you do have that where, you know, all you have there are fast food joints as opposed to a place where you can get, you know, fresh fruits and vegetables and everything like that.
Absolutely. So, you know, all of this goes into a more holistic approach to health, right? You know, not just treating the physical, but those structural upstream determinants that affect our health later on in life. So, all right, we'll go on. And this is one of my favorite models. We were geeking out about this, Dr. Scott. So this is called the socio-ecological model. It was first developed in the 70s, I believe, and then really conceptualized into a framework theory in the 80s. So the socio-ecological model is all about the interaction and the reciprocal relationship between person and their environment. And it assumes that, you know, the person affects the environment and the environment affects the person, which is, it makes sense, right? I think we can all agree on that. And it breaks it down into different levels of that environment. So we have the intrapersonal level, and you can see down here, we have like some examples of intrapersonal. So that internalized racism, stereotype threat, embodying inequities between person and person. Or I mean, between in yourself as well. And then the interpersonal is person to person. So that's that next level there, overt discrimination and then implicit bias. And then we go up to the next level, which is that institutional level, your organizations, your schools, the NGOs, food pantries, that kind of thing. So hiring and promotion practices under and over evaluation of contributions are different types of discrimination or barriers that can happen on that institutional level. And then we have the community level. So the way you interact in your community and what that community looks like for you. So that can be your friend group, that can be the PTA, the get together. It can be your city, it can be your neighborhood, what that looks like for you. But based on that community, you can have differential resource allocation. So I think, for example, one of that we probably all know is that our zip code is one of those factors that are most prominent, most important in predicting our health and our longevity. So I think I was at a conference in Chicago last year, and they pulled up the map of Chicago, and from one county to the next, there was almost a 20-year age gap difference in expected lifespan. So really showing that different level of resources from one to the other, and then whether there's more pollution in one community versus the other, or something like that. And then we have that systemic level. So this is that higher level of policies and legislation that govern the trickle down of resources and things like immigration policies, incarceration policies, and then predatory banking. So that's a kind of overview of the socio-ecological model, and something that you can use with your residents when explaining this, and maybe picking out levels that you want to look at and really zone in on, and maybe in projects or something like that. Is there any questions about this model or any comments? I know, Dr. Scott, you love this one too, so feel free to jump in.
Well, I was just going to reinforce what you said. I think one of the things I love about this model is that when we're teaching about health equity, and I've taught about health equity to undergraduate students as well as to medical students and residents, this model is really helpful because it helps break down a concept that can be overwhelming to think about, and to try to explain, especially because what my experience with medical students and residents is that they want to do something about it right now, right? Like, this is a problem and we need to do something about it. And so being able to break this down into these different levels, one, helps with thinking about where, and we'll talk about this later, where in your curriculum you may want to include this for your residency program. But it can also help people make an immediate connection to be able to say, okay, I can do something at this level right now. So I think it's really helpful in that way.
Yeah, that's a great point, Dr. Scott. Finding the bite-sized chews that you can go after. All right. If there's nothing else about that, we'll go ahead and move on to the next slide. So I think this is Dr. Scott.
Yes. All right. So we wanted to talk a little bit about what kind of training your residents may have gotten in medical school. And there is not a lot of really comprehensive research about this. Most of the studies about teaching social determinants of health or structural determinants of health in medical school are single school studies that are really looking at a change in knowledge or attitudes of medical students before and after some specific social determinants of health curriculum. And that can be really helpful research. Some of the curriculum is wonderful and has really good results in that area. And we're going to share some of those resources later. But this study was done in 2022. This is the only study that I was able to find that's more comprehensive, that surveyed a really broad range of medical schools to try to get a sense of what is happening in terms of training in this area in medical school. Just so that you have a sense of what your residents may be coming with. So this was a study of, they surveyed 161 allopathic medical schools or programs. Some of the medical schools had more than one program, and so it was the same medical school, but they surveyed both programs. That was very few. 38 osteopathic medical schools or programs, and 237 accredited physician assistant programs. So I looked specifically at the medical school data for the osteopathic and allopathic medical schools because they broke it down in the study. So from the medical schools, they did only have a 26% response rate, which I think is important to note. I think it's not unreasonable to assume that the medical schools that responded are the ones who are doing the training. And so the ones who didn't respond may not be doing the training. So I think that's really important to note. Only 6% of those that responded reported that they were not teaching social determinants of health content during the clinical phase of medical school. And so from this study, if you can base this on the 26% response rate, most medical students are getting something, right? They're learning something about social determinants of health. Most commonly, they're learning this in large group lectures or in collaborative learning environments that include service learning, so working with community organizations. But there is only 41% of the medical schools reported that they actually assess any behaviors of their medical students related to social determinants of health. So that ranges anything from recommending a connection with a community organization when they're seeing patients in their clinical settings, to acknowledging that social determinants of health matter in a case presentation. So a real range of behaviors, but only 41% actually assessed it. So it's hard to know exactly what medical students are coming away from medical school with based on this study. There have not been any comprehensive studies that I'm aware of that look at the outcomes of training at medical schools or of specific curricula that actually are focused on health equity or structural determinants of health. It's only social determinants of health, which is potentially a little bit different, although some of those things could be included, since people don't tend to define these terms when they're publishing their studies, which would be helpful. But there are I reviewed a number of studies of individual medical schools. And if you look across those studies, they do show that while the majority of medical students who participate in these studies have an understanding of the structural determinants of health, so things like structural racism, and understand that those have a strong impact on health outcomes, they are not able to identify specific ways that happens. So they're not able to describe what the connection is, which is really important if you want to intervene with your patients. So based on this, it seems like medical students are conceptually getting some training on social determinants of health and probably health equity and structural determinants of health, but are not necessarily getting the kind of on-the-ground practical training about what do I do about this when I'm seeing patients or when I have my own practice in the future. And so I think that's where residency training can really come in and help develop that further for students or for residents. Okay, we can go to the next one. Unless someone has any questions, I'm happy to answer any questions if anyone has questions about this study. You have the link to it if you want to read the study itself. Okay. So just for some more audience participation, and maybe we can contribute to the research and the knowledge in this area. What did you learn about health equity or social determinants of health? And I think since not all of us, I didn't go to medical school, so not all of us went to medical school. So in any of your formal education, what have you learned about health equity or social determinants of health? Was that part of any of your education?
It was not taught in my medical school, and I can remember being first introduced to it in residency. I had a professor who had some sort of Venn diagram that included social determinants of health. But beyond him pointing out that these factors are probably playing into what's happening with your patient, there really wasn't much discussion.
Yeah, that sounds really similar to what this research is finding at the medical school level. Anything else? I will say in my own training, I learned lots of theoretical models about health equity and social determinants of health and structural determinants of health. But there was, for me too, and I was in a medical anthropology graduate training program. There was a whole lot less on what to do about it. Even in anthropology, which I think maybe should be more focused on those interventions, but it was really more conceptual, which I think is actually parallel to what's happening in medical schools. All right. So I will say that I think this is really important that we do this training in residency. I also think one of the reasons that it doesn't happen as much as we might hope that it does, because it's really hard. It's hard to teach. It's hard to integrate into a busy residency schedule. So we're gonna talk about some ways that you might be able to do that.
All right.
Is this my slide too? This one is mine too, right? Okay. Thank you. Sorry. So, okay. So, I think everyone here knows that I was an associate program director for family medicine residency program for about 7 years. And my specific focus was on social medicine. And so I worked on developing training in health equity and social medicine across the residency curriculum. So, and this has been done in other places as well. And we have lots of examples of this. But I think, we need to think really broadly about where health equity training can be incorporated. So didactics is kind of the easy one, right? We could have a lecture like we're doing right now, about health equity and learn the concepts of health equity, maybe even give some examples of interventions that might work. But that's really, I think, not going to go beyond what what students are typically learning while they're medical students. And so while I think that's important and can provide a baseline for everyone, it might, it's probably it's the easy place, but it's also maybe the minimum. So you can go ahead and put the next one. You can put all of them up actually. So, whoops. Another place where I think is actually quite easy to integrate health equity, or maybe one of the easier ways, is in scholarly activity, and particularly in quality improvement. Because if you can identify a health disparity within your clinic, then you can design a quality improvement project to try to address that disparity. And that's something that's already required in residency programs. And so it fulfills that requirement, but it does so in a way that hopefully can be really meaningful for residents. So if you're seeing that there's a certain population within your clinic, say, within a certain demographic, say lower income, or within a particular neighborhood or a particular zip code or a certain race or ethnicity that has higher rates of uncontrolled diabetes, then there's some quality improvement that can be done around that. And you could identify and design interventions to be able to address that disparity so that you don't see those higher rates in certain populations and not others. And so I think that's another really pretty easy place to do that. In the Las Cruces program where I worked before, we also have specific rotations that really focus on health equity. In family medicine, there is a required community medicine experience, and that's often where health equity training comes into play. And that can be a really incredible experience for residents, especially if they get to spend time with community organizations and see the work that community organizations are doing and not be so focused on the clinical part of medicine in those moments. So just as one example, residents in Las Cruces spend time at the Community of Hope, which is a sort of campus that has a number of different services for people who have unstable housing situations. And so it's a food pantry and a soup kitchen and daycare and activities for children. There's a clothing closet. People can take showers, right? There's a lot of work that is happening there. And residents have an opportunity to attend a meeting with recipients of services from Community of Hope, where they talk about the things that they need and the challenges that they have and the things that they're struggling with. So residents are not there as physicians, they're there to listen. They're there to hear what's happening in the community. And that can really help people both see what the issues are, because these are people who may come to see them, right? They're in their community, but also can help them see what resources are available and what is happening in the community, and they can connect at that level as well. And there are other opportunities. We're going to talk a little bit about advocacy. You could have a health policy rotation where residents have an opportunity to really think about how they can have a voice at the policy level, whether that's at the legislature or even within their own hospital or clinic organization, to think about the policies and practices within their clinic that might contribute to health disparities and how those could be changed. So those are a couple of examples, and you can block off time, right? There, the way the Las Cruces program did it is that they did make those required rotations, which meant that people had fewer electives, but it doesn't have to be that way. It could be an elective, and residents who have a particular interest in that could do that rotation, choose that rotation. The things that start to get a little bit more difficult, maybe faculty development is not as difficult, but these next two bullet points are where it starts to get a little bit more difficult and does require some faculty development in order to really be able to do this well and do it on a regular basis. But you can also integrate health equity training into regular discussions and feedback in the clinic and in the hospital. So for example, I think it's, you may see a disparity between two patients that are in the hospital. And I know this has happened before. This is just one example. Two patients who had complications from diabetes, one who had an amputation and the other who had who there was a different kind of surgery done to save the limb. And so this discussion about why is it that one patient had the amputation and the other they were able to save the limb, right? And it certainly has to do with the medical conditions that people had, but it also had to do with the social context. One of these patients had limited access to healthcare, was unable to always get their medication, was dealing with a lot of stress in their life. The other patient, not quite as much. And of course, the one who had the amputation was the one who had all of these other kind of negative social determinants of health around them. And so there was an opportunity in the hospital setting to actually talk about that, right? Because both of those patients were in the hospital at the same time. And so I think it takes might take some development of your faculty and just some awareness and sort of looking out for these kinds of opportunities in the clinic and the hospital to be able to point out, hey, we're seeing a disparity here. This is what's going on. Is there anything that we can do at this individual patient level, right? Recognizing that we see this disparity happening. So I think that's important, and it has to be really intentional on the part of all the faculty, and probably need some reminders at different times to do that. And another one that I think is really wonderful opportunity, also sometimes can be a little bit challenging given the busy schedules of both residents and faculty, and also the fact that people are on different rotations at different times. It can be hard to schedule this, but if there's an opportunity for a residency-wide community collaboration, that can be a really wonderful opportunity for learning. So, for example, I'm just noticing the time. Sorry, I'll rush. Just one really quick example is that you could partner with an elementary school and residents, when they're on certain rotations that would allow them a little bit of free time, could do some mentoring activities with students. And so there's always a resident who can do that work with the school. It's not, or faculty, it's not always the same person, but it's that kind of organization to organization collaboration. So that's another possibility. And I think I already talked a little bit about faculty development, so we'll move on to the next slide.
All right. So thank you, Dr. Scott. She kind of gave us that intro into how we can get it involved into the teaching of residents. And here are some more examples of how to get that done. So when it comes to getting involved in policy or advocacy, some specific examples of how to do that. We have Doc for a Day program. There's the NMAFP and then the NMPHA, who both have opportunities to get involved with policy and to make a voice in changing and shaping what is pushed for and how it's worded, submitting some revisions, community voicing at the legislature. So you're able to, you know, call in via Zoom and speak in front of the legislature about any input you have on specific legislation. And then just be part of organizations that really push for health equity in our legislature. The health councils. So for example, in Las Cruces, we have the Wellness Council here that meets, I think monthly, and they really bring together all of the organizations or try to get all of the organizations in the county that work on that community level and try to advocate for bridging gaps that we find that lead to those health inequities. So you can always get involved with your specific county's health council and work with them on their projects. I know for the Doña Ana County one, there's always a period at the end or the beginning where we're given a chance to really talk about what we're doing and get involved with projects and other organizations and network there. So that's a really great opportunity. The Department of Health, I know that Dr. Scott mentioned that you can really work with them and send residents on rotations to their different clinics, their STD, their family planning clinics that they have, etc. And then also with QI projects, Dr. Scott mentioned a little bit about that, and we'll go in just a little bit more in this next slide on that. So I'll leave it for that. Not the next slide, the next slide. So for the sake of time, I don't think I'm going to go bring up any of these websites, so we have time for some more discussion at the end. But you will have access to these. And when you're looking at, you know, if you want to do a QI project or put a month of didactics in, you can really utilize some of these resources. So for example, the AHA one here, American Hospital Association, has a roadmap for health equity and measures that you can start to collect data on, or culturally humble ways of patient care, just a lot of different toolkits like that. The Health Equity Rural Health Info also has toolkits. This is more geared towards, like, if your program, your hospital community wants to develop a health equity plan, you can use that to really look at that. And then there's some others here that really have some great resources that you can check out. And I'm just going to go right on ahead. So NMPCTC is also trying to help with this, since we know that everybody doesn't necessarily have the financial resources or time to really create or look at how we can create a more equitable community and health for all. So we've applied for ABFM grant, which we should be hearing about any day. Cross your fingers. So looking at health equity QI toolkits that's being developed in UNM and Las Cruces, and how we can use those to measure outcomes at the clinical level for patient care and see what's going on for that. And we can talk more about that offline too if you're interested. Health equity curriculum, Dr. Scott talked a little bit about this, developed in Las Cruces, and has a few different segments to it. And we're trying to ramp that up and tailor it to each of the communities in New Mexico, so that it can be specific to the disparities seen with your communities. And then also creating a DEI plan for our organization. We're working on making sure that we are examples in the community about how we practice policies, procedures, and everything like that. So go on to the end. So thank you so much for being with us and your time. And I will open the floor for discussions and talk in these last 2 minutes.
Yeah, I think we do have at least 1 more minute. If anyone does have questions, you can, reach out now, or, how to find us.
right. Well, we are here. You have our emails below. I know most of you have our emails or phones, so feel free to call. And happy to talk about it more. And thank you.
Yeah, thanks, everyone.
Thank you so much. That was
Yeah.
awesome. Thank you.
Dr. Scott. Thank you, Nicole.